I am an emergency physician from the Alfred. I work with Paul and David and Jeff in the emergency department. And this morning I want to tell you the story about the patch trauma trial and then drill into some analyses on the appropriate dosing of TXA, or the lessons we can take away from the patch trauma trial. So does this work? No. So, for those of you not familiar with patch, it was a randomized control trial designed to evaluate the efficacy and safety of tranexamic acid in patients with severe trauma at risk of acute traumatic coagulopathy and being treated in advanced trauma systems. And the backdrop of this trial was the CRASH-2 study. CRASH-2 came out in 2010. It was a remarkable trial. 20,000 patients, fantastic randomization, very small loss to follow-ups, and it showed a difference in the primary outcome of 28-day mortality. No trial, looking at a single intervention in trauma, had ever shown a difference like this, even now. This is the only intervention in trauma that has shown a difference in mortality. And it appeared safe. There were no apparent increase in vascular occlusive events, and then a post-hoc analysis showed that it needs to be given early, and we've heard about that this morning. And so the major issue for us was, did we actually have equipoise to do another trial? And on Monday, you heard about reproducibility of results, how it's important. And what we found was that despite lots of other trials in the trauma population, those results have not been reproduced. Slightly different population, CRASH-3, no difference in primary outcome. There was this interesting difference in the mild to moderate group. Not really sure why. ROC, STAMP, TAMPITI, again, no difference in primary outcome. The results of CRASH-2 had not been replicated. STAMP came close. In one of their secondary outcomes, in the subgroup where patients received TXA within 1 hour of injury, and also in the shocked group, they did show a statistically significant difference. There is their statistically significant difference. Time from injury less than equal to 1 hour. 18 patients versus 10 patients. You can get your SPSS and Stata out and see if you can find the confidence interval with those numbers. They will cross 1. And same with that severely shocked group, 11 and 5 patient difference. The wording here was there was some adjustments made for site clustering that made those differences statistically significant. We did write to Professor Sperry. He confirmed that they were true, and it's still a secondary outcome. So the results of CRASH-2 have not been replicated in any trial so far. So we proceeded with PATCH. PATCH was a pre-hospital trial. You could not randomize or enroll patients in hospital. It had to be done pre-hospital. And one of the reasons it had to be done pre-hospital in the Australian setting is that our pre-hospital times are really, really long. It's a big place. It's sparsely populated. Injured patients just can't be found most of the time. And this is data from a recently completed different randomized trial that we ran. time from initial ambulance call to the ED is around 3 hours already. And this is initial ambulance call. Most of the time, these patients are not found. They're wrapped around a tree somewhere far, far away. And then from randomization, and this was in the helicopter, transport times, scene time and transport time together is often an hour and a half. So this had to be done pre-hospital, and we proceeded with it, with the patch trial. We copped a lot of abuse for the patch trial, and this was on a weekly basis. Russell and I were trolled on social media. We were called homo representatus. I'm not sure what that means, but that bowl in the hand is supposed to mimic the abdominal cavity. The spaghetti in there is fibrin, and the bolognese sauce is a blood clot happening. And TXA thickens that blood clot. And the point being made here is if you put the wallet in, add money to it, it makes no difference to the blood clot. It probably does. And this was not just from overseas. Even in Australia, our colleagues abused us for continuing with patch. How could we ethically not give TXA when it's a single intervention that's supposed to improve mortality? And a lot of our colleagues decided to break protocol and just give TXA. Yes, you've been randomized to patch. I don't care. Obviously, we'll stay blinded, but they're going to get TXA anyway. And it kept going, and it was a long trial. It got to the point that Russell had to leave the country. I think he left for other reasons. And we were not allowed to meet in Australia, so we had to go overseas and meet. And this is our first fibrinolysis meeting on patch many years ago. There's a few young faces in there. And this is where we planned all these sub-studies. How are we going to explain any differences we find in the patch trial? But look at the mechanisms of action, not just the primary outcomes. So the patch trial proceeded and was completed in 2022, and results published in 2023. Most of you would have seen this. Randomized 1,310 patients. We lost follow-up in about 170-odd patients and had the primary outcome available in about 1,100 patients. And what did our primary outcome show? Our primary outcome was not mortality at hospital discharge. It was survival with a favorable functional outcome at 6 months. We called up these patients at 6 months and asked them, how are you going? And we measured their Glasgow outcome scale extended. And we found no difference. Tranexamic acid versus placebo, risk ratio right on 1. It wouldn't budge. Regardless of how much adjustment we did, it would not budge. This is obviously unadjusted. And the interesting thing was, in the placebo group, and that's the bottom group, you see there is a higher mortality. TXA was associated with a reduction in death. But that equal number that died, or equal proportion that died, were represented in that low severe disability group. That's a highly disabled person at 6 months. They cannot function by themselves for more than 8 hours a day. Someone has to be with them. And the hypothesis it generated, secondary outcomes, hypothesis generating only, hypothesis it generated was, while TXA was associated with reduced mortality, it may result in more patients with severe disability. And that's a drill down into our secondary outcome of mortality, which showed that at both 24 hours and at 28 days after injury, there was a significant reduction in mortality. And of course, everyone decided we don't care about 6-month outcomes anymore. Let's just focus on prolonging life. We found it to be pretty safe. There was no statistically significant differences in any of the adverse outcomes. And so based on this, you put together CRASH 2 and all the other trials. It was an open license to give tranexamic acid. But at that time, no one really knew how much to give. A 1 gram bolus? And that's still in Australia was what commonly happens. Have you given TXA? Yes, we've given TXA. That's it. Let's forget about it. A 1 gram bolus, that's all people get. A 2 gram bolus? Sure, it's been popularized by Stump and Rock, and 2 gram boluses are commonly given. The trial in the protocol, 1 gram plus 1 gram. Sure, that's what's supported by the evidence, certainly supported by CRASH 2. What about a 2 gram plus 1 gram? If 1 gram's good, 3 grams must be better. And then patients go to theatre and the anaesthetist forgets that this is a trauma patient, not a cardiac surgery patient, and goes and replicates Atticus trial doses. 100 milligrams per kilo, 50 milligrams per kilo, Paul 12 milligrams per kilo. But it's just random number generation on how much TXA should be given. Even a protocol that Professor Broe put up on social media a few months ago, let's give some to the head injured people. Why not? So we decided to look at this dosing in a bit more detail. Now, thankfully, and this is one of the good things about people breaking trial protocol, is that does this work? Here we go. We had a lot of patients who had protocol deviations. Patients who received just a single dose and they didn't get another dose because they dropped dead or people forgot. And then there was these 210 patients who received open-label TXA. And they would have been spread across the placebo group, some who only got the 1 gram, and there was a small group who got 2 grams, plus they got another 1 gram on top of it. And so we decided to have a look at the association between these different doses of TXA and the outcomes of death at hospital discharge. We've abandoned the 6-month functional outcome for now. It was slightly tricky to design this analysis because the ones who got the 1 gram and did not get any more than that, a lot of them were dead. So they didn't die because they got 1 gram. They didn't get more than 1 gram because they were dead. And because these doses were administered at multiple time points, we had to take into account this thing called an immortal time bias. And we used a time-varying factor into the regression model to account for this. And what that essentially meant was that at each time point, since the receipt of the first dose of pre-hospital study drug, the mortality risk were compared among patients that were still alive. If they had died, they were censored. And what that meant was over the first 24 hours, these patients moved across into the different groups. We looked at vascular occlusive events in a very similar way. That patients had to be alive for their vascular occlusive events to occur or be measured. This is it's a pseudo consort diagram of what happened at the end of this process. So at the end of the 24 hours, we had those 4 groups that there were 541 patients with no TXA. Somewhere along the timeline, 170 only got 1 gram. A lot of them got the 2 grams. And then there was a very small group that ended up getting more than 2 grams, which does limit our conclusions, our ability to make any conclusions on that very large dose group. What did those groups look like? Well, that high 3 gram or more dose were younger. But otherwise, they were quite balanced. Interestingly, for people from the US in this room, we have a very high proportion of blunt trauma in Australia. Not many penetrating trauma. Most people are motor vehicle crashes, high falls, getting hit by cricket bats, not baseball bats. And the shock states were similar across the groups. But what we did find was that 1 gram group did have a higher proportion of patients with severe head or neck trauma, which is most likely why they had early death and ended up getting 1 gram. While the greater than 3 gram group were severely injured, and perhaps that is why they got more TXA, because someone decided, hey, this person's still bleeding, let's give TXA regardless of what they were randomized to. So we had to adjust for those variables in our regression analysis. In terms of the VT, of this outcome, there was no difference in the risk factors for clotting that we knew of. Family history, oral contraception, malignancy, smoker. These are young people. We did have a fair bit of missing data, but at least statistically we couldn't see any difference between the 4 groups. What happened? Well, the risk of death in the 1 gram group, and this is only up to 24 hours, is obviously a lot higher. This is not causation. This is just an observation, and all it tells us is that that 1 gram group died early. Not because they got 1 gram, but because they died and hence they did not get any more. So don't take this as even remotely associated with any causation. And this is, again, the unadjusted graph over the 28 days. That 1 gram group died early. And then we had to adjust for it. So when we did do the adjustment, what we found was that compared to not giving TXA, if you just gave that 1 gram of TXA, no association with mortality at 28 days. If we gave 2 grams of TXA, there's certainly a significant improvement in 28-day mortality. If you give more than 3 or more grams of TXA, small numbers, the point estimate is at 0.73, which is good, but the confidence interval crosses 1 because the numbers are small. Perhaps there's a signal that the higher dose is more effective, but hypothesis generating only. What happens with VTE events? Compared to not giving TXA, giving 1 or 2 grams were not associated with more VTE events. But giving 3 grams or more, even with that small sample size, resulted in a larger proportion of patients getting a VTE event. The patch trauma trial was unique in that we mandated that everyone get tested for DVTs at 7 days. So this data is a pretty true reflection of whether they got a VTE event or not. This contrasts a lot of the other trials where VTE events were left up to the discretion of the clinician to find out. So for our patients, everyone had to have an ultrasound on day 7. So, discussion points. Is TXA indicated among severely trauma patients? I'm going to put it out there. It's a bit provocative with our UK colleagues in the room. Is death at hospital discharge the ideal outcome measure? When our stroke colleagues have asked patients would they rather be dead or be severely disabled, the answer has been almost always death over severe disability. Is 6 months long enough to assess severe disability? Could these patients be getting better in the next 6, 12, 18 months? We are basing our treatment of our knowledge of TXA on still that one randomized controlled trial whose results have not been replicated. And then if you are going to give TXA, what is the ideal dose? We do observe a mortality benefit only after 2 grams. And given our trial used 1 gram plus 1 gram, I have to remain loyal to the trial protocol and say, well, that's the dose and regime that would benefit. A 2-gram bolus certainly could do the same thing. We don't have any current evidence to recommend higher doses. There are certainly signals of more vascular occlusive events with high doses, and therefore we need to continue vigilance for these VT effects. Thank you. That's all I've got. Thanks to all the participating sites.